Okay, so I would like to welcome all of you to our Zoom meeting today. And before we begin, let's just bow our heads for a short prayer. Let us pray. Our loving Father in heaven, we come before your presence. We thank you, O God, for your grace. We thank you for your goodness. We thank you, Lord, for keeping us safe and for this opportunity, O God, to be able to share some information about the shoulder, which we all struggle to solve. And we ask, Lord, for your guidance and your wisdom to be upon each one of us, wherever we are in any part of the world. And so we thank you for your guidance and goodness tonight. In Jesus' name we pray. Amen. So again, good evening, and I would like to welcome all of you to our presentation tonight. And the title is about revisiting the problem like the frozen shoulder. So this is an interesting study because we're going to discuss a lot of common things that we struggle with the frozen shoulder. So let me begin by citing to you a memory text found in Isaiah 40, 29 to 31. It says, God gives power to the weak, and to those who have no might, he increases strength. Even the youth shall faint and be weary, and the young men shall utterly fall. But those who wait on the Lord shall renew their strength. They shall mount up with wings as eagles. They shall run and not faint. Indeed, we as physicians do not always have the solution to our problems. And so we need guidance from someone higher than us so that we can be guided as to what steps to take as we move towards resolving this problem that we are facing. So I just would like to know if everybody can see my presentation right now. I think my computer hangs up. Hold on for a minute. What's happening here? Okay. Hold on for a while. I don't know what happened. It's not moving. Okay, let me restart it again, and we'll see how it goes. Hold on. Okay, so can you all see it? Okay, so adhesive capsulitis is defined as a common but poorly understood condition that's causing pain and loss of range of motion in the shoulder. It can occur in isolation or concomitantly with other shoulder conditions. So it could happen together with other problems, or it could occur all by itself. And most especially, it happened together with some risk factors that is usually associated with, like diabetes mellitus. So if you have a patient with frozen shoulder and has a diabetes, that exactly defines what these conditions is all about. Now, so in the past, it has so many definitions, and it goes all the way back to 1872 when this was defined as a scapulohumeral periarthritis. And only in 1934, Cadman coined the word frozen shoulder. And of course, in 1945, it was Nebuchadnezzar who actually called it adhesive capsulitis. And some people sometimes call it capsular contracture. So as you can see here, it's a condition affecting the shoulder itself. So epidemiology-wise, it occurs during the 5th to 7th decade of life. And as I mentioned earlier, diabetes is a predisposing factor, and it represents about 13.4% of the general population. And we always try to ask our patient, what is your dominant hand, right? And hoping that what would be involved in this condition would be the dominant hand. But in contrast to that, the involvement of this problem usually affects the non-dominant extremity, and the dominant extremity is only affected in about 30% of cases. So it's very surprising that it doesn't really affect the dominant hand. It goes with other comorbidities like thyroid problem, rheumatological diseases, hypoadrenalism, cardiopulmonary disease, cardiovascular disease, and if the patient has a previous trauma or surgery. So that's exactly what happened there. So it is a progressive syndrome, and usually it affects a lot of other patients. And as mentioned earlier, it affects both the active and of course the passive range of motion. And the basic problem is felt at the glenohumeral joint. And it also affects women more than men, with an incidence of about 2%, about 5% of the general population. And the prevalence of diabetes mellitus is up to 20%. So it's very common in diabetic patients. Now, if you are dealing with a frozen shoulder or supposed to be a shoulder problems, and you wanted to find out by ultrasound exactly what you are having, it's good to know that there are other conditions that could be seen in the shoulder. Sometimes when we approach the patient and we say, I have pain in the shoulder, what comes naturally is that, especially when there is limitation of motion, oh, the patient could be a frozen shoulder patient. So, but if you look at the ultrasound, there's a lot of other conditions that you can find actually. You can have bursitis, you can have rotator cuff problem, or you can have biceps tendinitis, you can have an impingement, or there could be some glenohumeral effusion or part of a degenerative joint disease or osteoarthritis. So all of these are actually present in patients suffering from quote unquote frozen shoulder. So the clinical presentation would be, as you all are familiar with this, is a gradual onset of shoulder pain with limited range of motion, and more specifically, there is a limitation of external rotation and of course forward flexion. So if you try to move the shoulders, the patient's shoulder, you would always notice these limitations to be present. And the reason why we would like to do an imaging is because we would like to exclude other causes, such as it could be a rotator cuff impingement, it could be a calcific periarthritis, it could be an inflammatory arthritis or an osteoarthritis. So in other words, when we deal with frozen shoulder, we have to make sure that we are not dealing with any of these conditions, and thus we can come up with the diagnosis for shoulder. So it's really a diagnosis of exclusion. And usually the pain is significant at night. And with all of this presentation, adhesive capsulitis or frozen shoulder is self-limited, but look at the range of time it could affect us. It lasts for 18 to 24 months. So if you tell your patient, okay, this is a self-limited condition, he would be happy about it, right? But if you add the other information which says, Okay, but this could last for 18 to 24 months. That could be a bad news for the patient. He might think it's self-limited and it could just go away by itself without any treatment, which is what we mean by self-limitation. But at the same time, we should make it realistic enough to say that it lasts or it could last for 18 to 24 months. And of course, the symptoms and movement restriction could go up to 3 years in about 40% of patients. And 15% of those patients could have permanent disability. So it's a bit frustrating to realize all this information to be present in our patient. Neviuser in 1945 made a study on the frozen shoulder, and he staged this in 4 different stages. So he called this pre-freezing stage, then followed by freezing stage, the frozen stage, and of course the thawing stage. And look at the amount of time involved. In the pre-freezing stage, there is a limited range of motion that could go up to about 3 months. And arthroscopically, there is erythematous fibrinous synovium for this particular duration of time. And then followed by the freezing stage, which is a severe restriction of motion that could last up to 3 to 9 months. So patients get frustrated, and most of the time, I don't know about you, but I always tell my patients, it could be worse before it gets better. So this is one condition that patient has to accept the fact that it really could be worse before you can actually solve it and go back to normal. And of course, the frozen stage could last for an additional 9 to 15 months with severe stiffness, but very minimal pain. Probably you can see a lot of these patients with difficulty trying to achieve their full range of motion, but didn't really complain of pain. They would just tell you, oh, it's very stiff. And then if you ask them, okay, can you raise your shoulder, please? And then as they attempt to raise their shoulder, you would notice that there is a lot of stiffness there. Then of course, immediately after that, which is actually has a different time period, could be a thawing stage with an improvement range of motion. I have yet to see this coming really naturally, even if we're saying it's self-limited. But again, there's a lot of other dynamics in the frozen shoulder condition. Now let's try to look at this other research done by Redler and Dennis in 2019, I should say, where he actually kind of classified the symptoms and simplify it together with the formation of scar tissue. So during the first stage, it's just purely inflammation. And during the second and third, depending on what phases are we following, the arthroscopic, the Neviuser, or the Hanafin stages, it could be a combination of pain and stiffness because of the fact that there is a scar tissue formation. And lastly, there could be just plain stiffness that we usually see in our patients. So here, we could see that the progress of this problem is that there seems to be really a real kind of struggle for the patient with this kind of problem. So by ultrasound, this is how it looks like. Of course, if you put your power Doppler and you go through the rotator cuff interval, I would say that is the beginning of where you actually have to identify the problems in your shoulder. So with the biceps tendon at the middle, and of course you are in a modified cross maneuver with your elbow pointing to the back, and then your hand at your gluteal area. Then this is exactly what you will see with all the inflammatory reaction contributing to the picture, to the real picture of what it looks like to have an adhesive capsulitis real-time by ultrasound. So this is your stage 1. And then as we progress, then we go to stage 2. And here, we can see that there are anatomic structures that could be involved. And one of these, and we will discuss this more lengthily, is your coracohumeral ligament. This is a very important structure when we talk about frozen shoulder, because this seems to be the structure that actually limits the motion that occurs in the shoulder. So histopathologic findings would confirm an inflamed subacromial and glenohumeral synovium with a hypertrophy of the coracohumeral ligament. So usually the coracohumeral ligament is only about 0.1 to 0.2, but sometimes it goes all the way up to about 3 or 4 millimeters, and that could be considered an abnormal findings of your coracohumeral ligament. Later on, we'll have to give you an idea where exactly will you check it and how do you measure it. And then, of course, as I've said earlier, the pathology always starts at the rotator cuff interval. So for those of you who are learning and doing ultrasound, you always have to begin scanning this particular structure, because this is where all the problems begin. So there is thickening of the coracohumeral ligament and your superior glenohumeral ligament. You know that this structure is very close to the biceps tendon, and we will show this later. By ultrasound, as I've said, there will be a thickened coracohumeral ligament, which is the main structure that involves here. And by MRI, you can also see an obliteration of subcoracoid fat. So these are very important findings that you have to see. So what are the relevant anatomy of frozen shoulder? So let's begin with the rotator cuff interval. So with the modified cross position, you put your patient, and you can see, if you look at the image below, the biceps tendon right at the center, the structure above it is your coracohumeral ligament. The structure towards the left and anterior and medial is your superior glenohumeral ligament. And then a little medial to that is your subscapularis tendon. To the right, which is actually on the lateral side, is your supraspinatus tendon. So this will be your focus of imaging. And there you can identify all the structures and make a comparison between your right and your left. Now, just to also inform you that there is such a thing as an anterior rotator interval and the posterior rotator cuff interval. So the thing that we are focusing right now is the anterior rotator cuff interval. But if you go more posteriorly, or should I say more laterally, then you can see that just below your supraspinatus tendon is your infraspinatus tendon, and that is what they call your posterior rotator cuff interval. But in this case, the problem really happens at the anterior rotator cuff interval. So just to give you more details and the positioning that you need to do, you have to put your shoulder in that position with a probe in an oblique axial view. And then this is what you see here, the biceps tendon in the middle and the coracohumeral ligament right above it. And you can see in the cadaver section, you can see here the details. So you can see the long head of the biceps tendon, and then just above it is the lateral coracohumeral ligament. And then you have your medial coracohumeral ligament. Those entire thing that surrounds the long head of the biceps tendon is the one that forms like a pulley system that actually prevents the biceps tendon from subluxating medially. So it is like a pulley that anchors the biceps tendon from moving in different directions. That's why if there is a rupture of the coracohumeral ligament, then that's when the biceps tendon will migrate towards the medial side. And then, of course, a very important structure that you also need to see here is the rotator cable, which I will show you also a little later. So here, this is another view and a diagrammatic representation of the details of the rotator cuff interval, since this is the one that we're trying to look at. And you can see that the coracohumeral ligament is actually envelopes the entire long head of the biceps tendon. It extends both medially and laterally. And then, of course, you can also see the superior glenohumeral ligament on the medial side, very close to your subscapularis tendon. And then on the lateral side, you have your supraspinatus tendon. So this is where you actually have to start. And of course, when you want to see the cable, and already here in this image is the cable is shown. So you maintain your position in that modified cross. And what you need to do in order to actually increase the sensitivity of the image to see the cable is you have to push the elbow towards the medial side. So when you are in a modified cross like this, so you have to push it more medially so that you can accentuate the cable that you would like to see, and you can actually measure it because it's just below your supraspinatus tendon. So here, what you will see in this area when we have an adhesive capsulitis is that there is an enhanced vascularity for patients less than 1 year of duration. But for those more than 1 year, then there could be an hypoechoic change. So the best way to actually look at this is when you compare the right and the left. And they say that this is the specific and sensitive sign that you will see in the ultrasound. Then of course, as you go along for more than a year, there could be a decrease in inflammation, as we also recall in the stages which we have shown you earlier. And then there could be a mature capsular fibrosis in chronic cases. Now, these findings, you have to take note because this will guide you as to whether you're dealing with an acute type of frozen shoulder or you're dealing with a case which is going more than 6 months at least. And you can see here that these findings correlates well with your arthroscopic findings and to some extent also your MRI. So you can measure the thickness in this area, and of course you can compare it with the one on the normal side. If you are looking at the MRI, for example, you can, the cutoff measurement is 6 millimeters. And of course, there is what they call the subcoracoid fat obliteration. But for ultrasound, you can actually trace them. And for those of you also who are doing intervention, the site between the coracohumeral ligament and biceps tendon is the site where you need to inject. So that space is where we actually inject to be able to release the capsular inflammation in that area. And we will also go through the solutions that we're going to use when we inject that area. Now let's go to the coracohumeral ligament. So as we have mentioned earlier, it originates from the base of the coracoid process. So you don't see it quite on top of the coracoid process. So if you would like to see it, it's really at the base, and it inserts both at the anterior and at the greater tuberosity. So as you have shown earlier, it wraps around the biceps tendon. It forms a biceps pulley. So if there is a rupture of this coracohumeral ligament, then there is a tendency for the biceps to subluxate towards the medial side. So again, this is a representation of the one that we have shown you. And this is the main structure that is affected with frozen shoulder. So look at the coracohumeral ligament. So it's inserted way below. It's not really above the coracoid process. It's a little below, and it's very close to your superior glenohumeral ligament in terms of its origin, because it actually is just beneath that area, but it inserts to the humerus in a very proximal area with the coracohumeral ligament. So again, this is another representation of how the coracohumeral ligament is oriented. So it comes from the base of the coracoid process. It's not really on top, and it goes all the way to the biceps pulley system that wraps around the biceps tendon. So this is another representation with a cadaver image showing how the coracohumeral ligament is related to the other structure, the biceps tendon, and of course the superior glenohumeral ligament. and how the biceps tendon also inserts into the superior portion of your glenoid. Now, the cut-off point of a thickened coracohumeral ligament by MRI, and of course later on by ultrasound, is 3.9 millimeters. The ultrasound is about 3 millimeters to be able to say that you are dealing with an adhesive capsulitis. Why is this very important? Because as we go along, we will find out that there are other conditions that can simulate a frozen shoulder, which is not really a frozen shoulder. It could be a secondary type of a frozen shoulder because the cause could be a rotator cuff disease or osteoarthritis. So finding the thickness is important as a basic information to be able to diagnose that you're dealing with a frozen shoulder. Now, as you can also see by other studies, just like the study of Lee, ultrasound has a better visualization of this structure than the MRI because you can do dynamic imaging. You can move your probe and be able to see all the details of this particular ligament. So this is how you have to measure it. So you put your probe in a transverse manner, and then from the coracoid process, then you try to kind of put your shoulder in an external. Of course, the patient at this point may not be able to do an external rotation, but you can actually just allow the patient to move to as much external rotation as possible, although it is painful. You just have to support him, and then the maximal way of external rotating the shoulder he can afford, then you have to view this structure. And you can see here a comparative image of what seems to be a normal structure of the coracohumeral ligament at 1 millimeters compared to that of a thickened coracohumeral ligament that is present in adhesive capsulitis. So anything that is more than 3 millimeters is considered to be an abnormality of the coracohumeral ligament in a frozen shoulder. So this is another way, but this is in a sagittal view, and it may be difficult for some of you, but just the same, you can also measure that and compare the normal to the one that is involved. So again, more than 3 millimeters could indicate a frozen shoulder or adhesive capsulitis. So of course, we know that the MRI can also identify that, but the ultrasound has a very good accuracy at 88.2%, and it is better visualized in ultrasound, especially in external rotation. So don't forget that you have to kind of external rotate shortcut, even a bit of it, to be able to see all these details. So it could also be seen as a linear hypoechoic band surrounded by fat, as you have shown here in the image on the upper right, and it is thicker by 3 millimeters to be able to diagnose adhesive capsulitis. And when this is thickened, it correlates with limitation of external rotation and internal rotation. So this is very important, because when you try to examine the patient, of course, you don't jump right away to ultrasound. You have to check what limitations of motion is present. If you notice that the limitation is external and internal rotation, then you can make a guess that your patient may have a thickened coracohumeral ligament. So this one would help a lot. Now let's go to your axillary pouch or your inferior glenohumeral capsule. So as you can see, this area is bounded by your inferior glenohumeral ligament. So right above, you have your superior glenohumeral ligament, and right below it, you have your inferior glenohumeral ligament, and in between that, medial glenohumeral ligament. So, posterior,
لا حبيبي راح نتغدى بيها ثاني وبابا. انت ما تتغدى نونو؟ ما تتغدى ويانا؟
request our attendee to please mute, please. Okay, thank you very much. Okay, thank you. So here, the inferior glenohumeral ligament complex bounds the axillary pouch, okay? And this one is the one that provides resistance to both your anterior posterior shoulder dislocation. So why we don't dislocate is because of this inferior glenohumeral ligament. But this is also very close to an axillary muscular bundle. That's why when we view this by ultrasound, we have to be very careful, because when we go to that area and put and check for the inflammatory reaction, we might actually just see the bundle that could actually tell us that this is inflamed, when actually it is just the neuromuscular bundle that is present. And just for our information, this particular ligament has a role in the stabilization of your shoulder. So how do they look like? So right here, what you do is you take a view of that particular area at your axillary portion in both coronal and axial view. So let's begin first with the axial view. So when you put your probe in the axial view, you can see actually the black portion, which is the cartilage right above your humerus, and then that thickened hyperechoic structure is your axillary pouch or the capsule. And then on both ends, you can have your inferior glenohumeral ligament, which is posterior. The clue is that it is close to your coracobrachialis. And then, of course, on the other side is the anterior band. And the anterior band is the major finding that you see in this particular pathology when you're dealing with frozen shoulder. So you have to measure. Usually, the normal measurement of the capsule in this area is 1 millimeters. So anything also above 2, sometimes 2.5, it varies between the 0.2 to 2.5 millimeters could be considered an abnormality. So in excess of that is already abnormal. So the only way to do this is to be able to, for the patient to actually abduct. Of course, I'm going to show you another technique. So this is just for the presentation that we have to let you see that it is very visible when you actually abduct your shoulder at 90 degrees. But most of the patients with frozen shoulder cannot do this. So there's another technique for doing that. So let's just move on to this. So on the other side, the coronal view, you will notice here that there is also that band, okay? And that is also your capsule again. And of course, it could vary from one side to the other. So it's always important to compare it side to side. And anything that is more than 2.5, in this case, it's 4 millimeters, is considered to be an adhesive capsulitis. So this is the importance of really knowing, based on evidence by ultrasound, how it really looks like. So here, the reason why sometimes the cutoff could vary is because there may be some patients who are asymptomatic, but there could be a thickened axillary pouch as well. So it is very important to realize that even as we try to do this scanning, we can see patients who are not complaining of anything, but still showing no signs at all. So when you have a measurement of more than 2 millimeters, it correlates with an MRI findings of adhesive capsulitis. So that's based on a study by Cerny. And the entire thickness could also be measured, although I would prefer just measuring the anterior side because that's the first one to be affected. And just for your information, it correlates with both MRI and of course arthroscopic study. So that only gives you more confidence in doing it because of the fact that it is almost similar with what you see in MRI and by arthroscopy. Okay, I think it hangs again. I don't know what's happening with my computer. Hold on for a while.
Doc, you're muted. Doc, you're muted.
Sorry, I'm sorry. Okay. So right here, thank you for that. So here, you will notice that the capsule is very thick. So you can look at the illustration on the left where the patient externally rotated, and you can see the same signs of stiffness that is found in this particular image. And anything that is more than 2 millimeters should be considered abnormal. Okay, so what I usually do is just put it in the middle. You can also see that if you don't externally rotate, you can hardly see the structure. I have tried that several times, and just to view that particular capsule there, if you just put the shoulder in neutral position, you won't be able to see the capsule. So you really have to do some kind of an external rotation. I know it will be difficult for the patient because the patient is already limitation, but you just have to exert some effort to allow the patient to do it in external rotation. So you will see the capsule right there. So here, it is a comparison between a normal capsule and an abnormal capsule because of the adhesive capsulitis. And you can see here that it kind of bizarre, no pattern at all. You cannot see the fibrillar pattern, which could also be present in the capsule, but this is just a disorganized type of swelling in an adhesive capsulitis in the presence of this condition. So again, this is another illustration of what we did a while ago on how you can measure the capsule in the axilla. Of course, this is very easy to do when the patient is normal, but if it is abnormal, then it's very hard. Now, here also is an image that compares what is normal and what is abnormal. So you can familiarize yourself with how it looks like between the patient with a problem of adhesive capsulitis versus the one that is really normal. So you can view here the difference in terms of the thickened capsule. Now, it is important that we kind of differentiate this with other conditions. For example, am I dealing with really adhesive capsulitis or just a synovitis? So how do I know the difference? So here, you will notice that on the left side is an adhesive capsulitis, on the right is a synovitis. Look at the pattern. The adhesive capsulitis thickening is straight. In other words, it's uniform. In synovitis, it's bulging because of the presence of the fluid in the joint. So that is the clue. And when you do an eggshell view, you don't seem to get all the difference. So you have to do it always in orthogonal views, both eggshell and coronal or sagittal versus transverse view. So you will be able to see all the difference and really make it real that you are dealing with a frozen shoulder. Also, it is important to also differentiate this with degenerative joint disease. Look at the difference. If you check the rotator cuff interval, which we say earlier, where the problem really starts, then you don't see any difference at all. You look at the findings, they're just the same. What you see in the degenerative process is also what you see in adhesive capsulitis. But when you do it in the axillary approach, that's where you see the difference. Look at the thickness of the capsule when you view it in the axillary versus if you do it in the axilla in a degenerative process. The degenerative process simply looks normal, seems to be normal, but look at the one in the adhesive capsulitis, it's thickened. So again, it's very important to always view the axillary area to be able to diagnose quite surely that you're dealing with adhesive capsulitis. So this is just an image of how to actually do it. Of course, we've shown that to you a while ago. And of course, there are different techniques. You can do it this way. Now, in this study by Kim, not the same as the one that was previously shown that you have to abduct your shoulder at 90 degrees. In this case, you only have to do it at 40 degrees. And you can see the pattern here that you would like to see. So just by putting the probe like that at 40 degrees, because the reason why it's like this is because a lot of our patients are limited in its range. So this is the most that maybe you can do for your patient, but still you can see the axillary recess and of course the capsule there. Okay, so this is also the same 40-degree abduction, of course, and then you can see the findings in the capsule here. And of course, again, you can compare it with the normal side and the when affected side, and you can see how different they are from each other. So the main pathological findings here is that you see it at the rotator cuff interval, and of course at the axillary recess capsule with 40-degree abduction. And of course, you can see that the coracohumeral ligament is thickened, and the other thing that you need to do is the range, especially in abduction, is limited by the glenohumeral ligament. Now, I summarized the area involved when you do your range of motion. So if the axillary area is already involved, there's a lot of limitation that is happening. In other words, your forward flexion is limited, your lateral elevation is limited, your external rotation is limited, your abduction with external rotation is limited, your hand behind back when you are doing your modified cross cannot be done when you have an axillary pouch involvement in this area. But if you are having problems with coracohumeral ligament and rotator cuff interval, you usually have only a limitation of the external and internal rotation. So you can already figure out what structure involves just by doing your range. And so this could be a guide for you to help you determine what structure could be involved when you examine your patient. So treatment approaches. Of course, we have different way of approaching the treatment, but if the patient is between your stage 1 and stage 2 or phase 1, phase 2, then you can probably just start with NSAIDs, physical therapy, Steroid in this case could be very helpful, but you have to be very careful that you don't put it in the ligament itself, because that will make that structure very, very fragile, and it might just break off. Then when you go to the stage 3 or phase 3, or sometimes with the Neviaser classification, stage 3 and 4, then you can, and there's no improvement yet, then you think about capsular release under ultrasound, or you can do your manipulation under anesthesia. So depending on what options you have in your area. So when you do a corticosteroid injections, we know it's a self-limiting. So we have defined what we mean by self-limiting. Self-limiting means it can recover by itself, but it will take 18 to 24 months. So if you tell that to your patient and say, what? You're letting me wait for 18 to 24, he would not like that idea. And then of course, it will take 2 to 3 years to resolve. And diabetes has 2 to 4 times likely to develop this condition than the non-diabetic. Corticosteroids has a very short-term efficacy, so just for you to know that. And physical therapy have equal effectivity as corticosteroid, so you just have to consider that as well. And then if you do injections, it's always better to do an image-guided injections so that you can see you can see the structures than just palpating it, because I know you will miss the most important structure that you're gonna inject if you don't use your ultrasound. So between using a 20 milligram or 40 milligram corticosteroids, no difference. So the study shows no difference. How about physical therapy as compared to platelet-rich plasma? It says here, it has been concluded that it has a comparable effect in terms of pain reduction, improvement, functionality, shoulder joint ROM, as compared to conventional physical therapy. So in other words, it could be a good alternative for those patients with very low compliance and has contraindications with steroids or pain medications. Now, how about if you do an intra-articular distension? So sometimes you inject it inside a joint. This study is very interesting because what they did was they inject either before the physical therapy, and the other one is after the intra-articular distension. So the result shows that if you inject first the joint by doing intra-articular distension, followed by physical therapy, that gives you a better result than if you start first with physical therapy and then end with intra-articular distension. So this might guide you in your decision-making as to whether you should start first with physical therapy or you should start first with injection. So which one would you want? But study shows if you start with injection and end with physical therapy, that has a superior results than the other way around. What about if you have to inject between anterior and posterior approach? Okay, some people say, okay, I probably should do the posterior approach. Some would say, okay, I think it's easier to do the anterior approach. Okay, this study, okay, this was published 2020, this is very recent. It concluded that the anterior approach is clinically and functionally effective than the conventional posterior approach. But it is easier to access actually the anterior approach, because sometimes you need a curvilinear probe and to access that area, and you might even struggle to hit that part. But as I mentioned earlier, where do you inject it? You inject it between your coracohumeral ligament and your biceps tendon. So that space in between, that is exactly where you need to inject that. If you go beyond that point, you're going into the joint anterior glenohumeral joint itself, which is very close to your subscapularis tendon. So I'm gonna show you here. This is a study by a group of Kevin, and what they did was they inject that area between the coracohumeral ligament and the biceps tendon, but as they go forward up to your subscapularis tendon, that's already a joint space, the anterior joint space. So you can actually hit 2 areas in one injection. So in other words, you can hit the space between the coracohumeral ligament and biceps tendon. Then as you move forward, you can also hit the joint itself. So this is indicated for the mild to moderate type of adhesive capsulitis. So you look at the approach, you approach it from superior to inferior in an oblique lateral to medial approach. How about comparing your platelet-rich plasmid corticosteroid at 12-week follow-up? A single dose of PRP injection was found to be more effective than your corticosteroid injection in terms of pain, disability, range of motion in adhesive capsulitis. Then what about shoulder manipulation under ultrasound guided? So there are times when we feel so frustrated, and so we say, okay, let's just refer that to the anesthesiologist. They do their manipulation under anesthesia. And what happened is that they inject it also between your CHL and biceps tendon. And this is also very important because it can also reduce pain. It's almost like the thing that we are doing. But what they did after that is demanipulate it further. Now, I would just like to caution you about the manipulation thing because these are the side effects of the manipulation under anesthesia. You might have humeral fracture, you might have dislocation, you might have brachial plexus traction injury, you can have intra-articular damage to your cartilage, you can have labral detachments, slap lesions, glenoid rim fractures, and rotator cuff tears. So these are the side effects of manipulation under anesthesia. So just a caution if you decide to do that because of your frustration to solve your frozen shoulder. So other known treatments are, of course, nerve blocks. You can do your perineural injection therapy, distension arthrography, and then arthroscopic capsular release, or you can do your open release as well. So these are options which is very available when it may be in your place of practice. So in summary, the best way to actually diagnose this is arthrography, but as we mentioned earlier, ultrasound can identify a thickened coracohumeral ligament more than 3 millimeters, a thickened inferior capsule more than 3.5, and of course, a rotator cuff interval abnormality. Those three things are important to make a diagnosis for adhesive capsulitis. And of course, we know that the central pathology is, of course, synovial inflammation and capsular fibrosis. So ultrasound diagnosis is a reliable method of diagnosis to identify specific areas of involvement. And as we mentioned earlier, just 3 structures that you need to see: rotator cuff interval, coracohumeral ligament, and the axillary recess capsular measurements. Your treatment could vary depending on what options you have and the stages you are encountering the patients. So know the side effects of manipulation under anesthesia. And then if you have arthrography in your place, you can do that. But ultrasound is a very helpful modality for diagnosis. So thank you very much for your attention.